afternoon, everyone. Before I go into the story of how we designed this technique of modification in macular hole surgery, I would like to tell the audience that I'm offering a surgical technique which gives you 2 bonus points. You don't have to do a fluid air exchange or gas tamponade. You don't have to buy something, dye to stain the internal limiting membrane. And this technique, has, in my hands, has given me 100% success rate. So friends, today I'm going to speak on macular hole surgery without gas tamponade by the macular plug technique. So why gas or air? It is to keep the macula dry, to tamponade the macula and prevent the bulk fluid flow through the macula. If that is the function of air, the amount of air in the vitreous cavity will determine whether the hole closes or not. And if you have a full tamponade of cavity that is filled with air or gas, you need not position the patient. And if you also look at literature, you'll find that there are various studies which show that no positioning has been advocated in the postoperative period. The first report was by Tonabe et al. And in all his cases, phaco-vitrectomy was performed. If you look at the subgroup of patients on whom we are performing macular hole surgery, we are operating on an aging population who have arthritis, other comorbid condition, and in a patient social scenario, majority of our elderly patients are alone, fending for themselves. And if they have to lie in the prone position, it's very, very difficult for them. My first patient on whom I performed this technique was a 60-year-old, very active chartered accountant. He was very obese, about 110 kg, and under no circumstances could he lie down in the prone position. That is when we devised this technique. And why I use autologous blood? The blood components, especially the platelet components, have been used since 1990, in the early 90s for macular hole repair. And there are various studies which have shown that the entire surgical procedure can be performed only with autologous blood. So the modification of the technique that we employed was for large stage 3 and stage macular holes of a mean base diameter of greater than 1000 micrometer. We did a very broad internal limiting membrane peeling to ensure that all tangential traction on the hole is gone. We did an inverted internal limiting membrane flap repositioning in multiple layers and gently tucked it under the edges of the hole and used autologous gluconated blood, where we withdrew 2 cc of blood under sterile aseptic precaution from the patient's antecubital vein, mixed it with 2 cc of 5% dextrose. It was done after the start of the procedure. The area where the blood was drawn was the antecubital vein. The area was prepped and draped. So this is a brief animation. This is the first layer of the macular plug, which is the autologous gluconated blood. The internal limiting membrane is inverted into the hole and layered over with blood. This is the internal limiting membrane being inverted into the hole, and it's gently nudged under the edges of the hole to form a macular plug which mechanically stuffs the hole. And it's layered over with a little bit of autologous blood which disappears by the first postoperative day. Postoperatively, on performing OCT on the patient from first postoperative day, there is no prone positioning. It is done as a daycare procedure. My patient goes home 1 hour after the procedure. We could find that the retina reapposited at the macula, starting from the inner retina to the outer retina, and by the 30th postoperative day, the hole closure was complete in all our patients. The complications that we saw was the persistence of redundant floating internal limiting membrane, which persisted for 12 months into the postoperative period, and inner retinal waves, both of which did not significantly affect the patient's visual recovery. This is one of the patients on whom this procedure was performed, a young patient about 40 years old. He's a laser technician, and he was performing laser in a dermatology clinic using the Q-Switch 1064 nanometer laser without protection, and he developed a large hole about 1472 micrometer size. This is on day 1 when you can see a loose plug bridging the hole. This is on day 7, there's a well-formed plug in the hole. By day 14, you can see that there is restoration of the outer retinal integrity, and we could give him a vision from 560 to 6/9. My friends, and why should I choose some other technique? When I have a technique which gives 2 bonus points to the patient, and I can ensure a 100% hole closure rate. I thank you very much for your kind attention.